Director. This meeting's being recorded. I'm the program director here at Cancer Support Community at Northwest Medical Specialties, and just wanted to start the program tonight by telling you a little bit about our affiliation with Cancer Support Community. So Northwest Medical Specialties, we've been an affiliate of Cancer Support Community for almost going on 5 years now. And Cancer Support Community is a worldwide organization that provides free supportive programs to people affected by cancer. So through this affiliation, we've been able to provide supportive programs like tonight's presentation on multiple myeloma to people here, right here in this community, and not just to Northwest, but to anyone in the community affected by cancer. So very, very honored to have Dr. McCroskey here tonight presenting on multiple myeloma. And as we get started, I just want to go over just a few kind of housekeeping things and introductions to the program. So tonight's slide was provided by slide deck was made by Cancer Support Community and reviewed by Craig Cole, MD. These slides were also reviewed by Dr. Robert McCroskey, who's presenting with us. And just so you have full disclosure. So again, these are a program that we can provide because of our affiliation with Cancer Support Community. And basically, they have the final control over kind of the content of these programs. So this is Dr. McCroskey, and he has no financial relationships or affiliations to disclose of for tonight's presentation. Okay, so now to the housekeeping. So we've muted everyone upon entry, and we just ask that you just remain muted during the presentation so everyone can hear clearly what Dr. McCroskey is going to share with us tonight. We have allotted some time for questions at the end. If you have questions that come up, please put them in the chat box, and then we'll make sure to get to those questions, and so that way you won't forget any. Best viewing option is to use the speaker view. So you should see next to the row of videos a grid. If you click that, there is an option to say speaker view, and that way you can see Dr. McCroskey and the presentation clearly. And we will make these slides available after the presentation along with the recording that will be on our YouTube channel. So I think that's all I got. I'm going to hand it over to Eunice Chua, who will be introducing Dr. McCroskey.
I forgot to unmute myself, so I'll start over. Welcome, everyone. Thank you so much for joining us tonight. We are very, very excited to have Dr. Robert McCroskey presenting this workshop. He attended medical school at the University of Washington, residency at Maine Medical Center, and there's some information about his fellowship. We are very excited to have him as he sees a lot of hematology patients. So thank you once again, Dr. McCroskey, and I'll pass it over to you.
Okay, great. So anyway, this is I'm happy to do this, and I'm grateful to the organizers and to the Cancer Support Community who put together this nice slide deck, which takes out 90% of the work, not having to make your own slideshow for a presentation. And we're going to talk about multiple myeloma, which is a very interesting and relatively common form of cancer that arises predominantly in the bone marrow. And after chronic lymphocytic leukemia is the second most common cancer of the blood, bone marrow, and immune system. Today's discussion is going to go over these primary topics. Sort of what is multiple myeloma, how does it present, how is it diagnosed, treatment options, your options as far as finding a care team and then some coping mechanisms. And I think we can go through it fairly quickly and hopefully leave plenty of time for questions and answers and a raffle. So moving on. So multiple myeloma is a cancer that arises in the immune cells, which arise predominantly in the bone marrow. And this is a specific type of immune cell, which is derived from what we call B lymphocytes, which mature into cells which are called plasma cells when they have the ability to make antibodies. In a normal situation, let's say one is infected by a COVID virus or some other foreign organism, the immune system will react and plasma cells will be produced and produce antibodies directed towards that foreign infectious agent. And there will be many different clones of plasma cells. And each clone, the antibody that's produced is slightly different. And we call that a polyclonal response, immune response. And you can certainly detect antibody levels, and you can, with sensitive techniques, tell that they're directed towards whatever organism you're concerned about. But in multiple myeloma, something happens, and this is happening, autonomously, without any, without any foreign body to be directed the immune response towards. So cells mutate, and most of the time they start making antibody. And in this case, it's one clone, and the antibody that is produced is identical. And so you can detect that there is a large single clone of cells based upon this single population of antibodies, which is measurable in the blood or urine. And that's called an M protein or myeloma protein, which is really an antibody or part of an antibody. And this M protein is discussed repeatedly going through this presentation. But just to know that these are arising from immune cells, and the M protein is reflection of the antibody made by those immune cells or part of a full antibody. Okay. And when patients have advanced multiple myeloma, it can cause destruction of bone. It can cause the myeloma proteins, these antibodies can get deposited in the kidneys and cause injury. It can displace the production of normal blood elements in the bone marrow and cause a drop in red blood cell count or anemia, and conversely can also cause problems in platelets or other normal white blood cells. And you can see abnormalities there, and that can actually grow. It starts within the bone marrow, but it can expand outwards into the bone and cause bone problems. And so for advanced multiple myeloma, they have this, it's the acronym is CRAB, for high calcium, renal damage, anemia, or bone pain. And it's good to remember that when you're looking at somebody, because multiple myeloma can range from a very low grade, benign process to something which is highly aggressive that requires immediate treatment. Okay, moving on. So what causes multiple myeloma to occur? We don't really have very many patients where we can identify that something drove this to occur, like this patient was exposed to some toxin and that's why they have myeloma. It's not like smoking is related to lung cancer. But what they're saying here is that there's something causes a mutation to occur, or mutations occur spontaneously for the most part. And some of those mutations take hold and allow for proliferation of a clone of cells within this community of immune cells to develop these abnormal plasma cells, which can get to the point which is called multiple myeloma. So as it said, the exact cause may not be clear. Moving on. So the only agent that I know of, and I don't know how clear it is associated with multiple myeloma, but Agent Orange exposure is, if you have multiple myeloma and you were exposed to Agent Orange and you were a veteran, then the VA finds that you are qualified for receiving benefits based on the assumption that Agent Orange contributed or caused you to have multiple myeloma. Outside of that, there are some clusters of families that have a tendency towards mutations that can cause multiple myeloma. It's really quite rare. Although if you do have a family member with multiple myeloma, you are at greater risk of developing it yourself. The first sentence here says 132 people are diagnosed each year with multiple myeloma. That's really not correct. 1 out of 132 people will have some form of myeloma in their lifetime. So, so out of 132 people, 1 of those will at some point develop myeloma. And myeloma can happen at any age. It's very rare below the age of 30. And the majority of patients with multiple myeloma are over the age of 60, with it often presenting as old as, as patients in their, or individuals in their 90s. For some unknown reason, African Americans have a twofold risk of developing multiple myeloma. Men have a higher risk than do women. I wasn't aware until I looked at this slide deck that that being overweight was a risk factor for multiple myeloma. And then patients who have there are precursors to multiple myeloma, which we'll talk about, which are plasma cell disorders, which don't quite meet the diagnosis of myeloma. And those are risk factors for progressing to multiple myeloma. And the one that we think about most commonly is monoclonal gammopathy of uncertain significance. Moving on. So more about the CRAB diagnosis. I think we kind of went over this pretty well, but this is when patients present with advanced multiple myeloma. And really, it's a minority of patients with multiple myeloma who present with kidney failure, bone destruction, anemia. We generally catch it these days at an earlier stage, but certainly patients do present with these CRAB features. And it's something that when you start to see this, you definitely need to think about this disorder. Moving on. So multiple myeloma has, because of this monoclonal protein or M protein, and the multiple manifestations it can have on kidney function, calcium, blood counts, there's a number of ways that we both diagnose it and follow treatment for improvement or response to treatment. And it includes blood tests, including specific tests looking for these monoclonal proteins, and then looking also specifically for the myeloma cells generally within the bone marrow. And chemistries are also important. We're talking about chemistries looking at calcium and kidney function. Okay. Myeloma proteins can also be detected in the urine. So we look both at blood and urine, and then we also look at the skeleton to see if there's any destructive lesions within the skeleton. It's very important when we're initially diagnosing multiple myeloma to do a bone marrow biopsy to quantify the amount of cancer cells on a bone marrow specimen, and then look at the genetic makeup of those bone marrow cells to help us know, sort of risk stratify, lower risk to higher risk multiple myeloma, and in the future maybe using that to help pick what is the optimal therapy, because myeloma is a heterogeneous disease. Okay, moving on. Again, this is just for patients who have multiple myeloma. There are many different labs that are used to diagnose and to follow progress with multiple myeloma. And not everybody has the same expression of those labs. Some people do not express abnormal protein in the blood, but only in the urine. Some patients many patients are not bothered by anemia or loss of kidney function. But we continue to monitor those things, making sure that that either that the kidney function is getting better, for example, and we do monitor this monoclonal protein to see whether or not that is because it's a marker. If it's increasing, then that's an indication that your myeloma is not responding to your treatment or is progressing after completing a course of treatment. Moving on. Next, Eunice.
I'm sorry, that's my fault. Yeah.
No worry, no worry. So diagnosing multiple myeloma. So, it's kind of interesting. These monoclonal proteins, when are often detected because we do so much blood work that we often will find that the protein level is high, which will lead to an investigation and show that that high blood protein is actually a monoclonal protein or an M protein, which then leads, is this possibly multiple myeloma? Well, really, of patients who have these abnormal monoclonal proteins, only about 25 to 30% are multiple myeloma. And of those, many of those are in an asymptomatic or pre-myeloma state that does not require treatment. But a good number of patients just have an abnormal protein, but do not have significant increase in plasma cells or any of the other features of a destructive multiple myeloma. And that's called monoclonal gammopathy of uncertain significance. And here you can see that it is relatively benign with only a 1% risk per year of progressing to multiple myeloma. It takes an awful lot of workup to try to get to that point that you just have MGUS or monoclonal gammopathy of uncertain significance. But once you have made that diagnosis, it's a relief to the patient and to the doctor or treating providers, and those patients do need follow-up for life, but that follow-up can be pretty infrequent. There's a more aggressive form, but it's still a pre-cancerous condition called smoldering multiple myeloma, but this smoldering multiple myeloma is included in that 1 in 130 patients a year. And these patients have higher risk features and, most importantly, greater than 10% plasma cells or abnormal plasma cells in the bone marrow. And these patients have as high as a 10% risk per year of progressing onto multiple myeloma. So they are monitored more carefully. And some of those patients who are particularly high risk have been found that we might as well just start them on treatment, even though they don't meet all criteria for diagnosis of multiple myeloma, which we'll get into in the coming slides. Plasmacytoma is a unique finding where multiple myeloma is, sometimes it's more concentrated in one area and actually forms a mass. It's relatively uncommon. Usually multiple myeloma presents with widespread involvement of the bone marrow and sometimes little focal areas where it's starting to grow out to the bone marrow and cause destruction of the bone. But some people present with isolated tumors, usually on their bones, but can sometimes be in other soft tissues. And occasionally it can be just a solitary plasmacytoma, in which case they tend to do very well when recognized and treated with treatment, either surgery or radiation therapy, and a course of myeloma therapy. Symptomatic or active myeloma, again, you have to have, there's diagnostic criteria, which we're getting into in the coming slides. So multiple myeloma, if you have any of these CRAB features and plasma cells of greater than 10% in the bone marrow, you're said to have multiple myeloma. If you do not have any of those CRAB features, you can be diagnosed as having multiple myeloma for under other situations, such as you have greater than 60% myeloma cells in the bone marrow, or you have some other identified high-risk features, and those high-risk features include very high monoclonal protein, and primarily in the blood or the urine. Moving on. Oh, okay, there we go. Matching the right medicine for each patient. This is actually not really quite ready for prime time. There is one situation in relapsed multiple myeloma where specific genetic mutations, which are driving the multiple myeloma, these patients have shown that they're amenable to a certain drug combination, including an oral medication called venetoclax, which is used primarily in leukemias. But other than that, this is something which is being studied, in great depth at this time. And I think that treatments of myeloma will be tailored towards mutations in coming years, as we are doing increasingly with other forms of cancers. But the genetics have long been recognized that there are many different genetic mutations which can end up causing the presentation that we call myeloma, and that some of those mutations have a prognostic significance, meaning that they can be associated with a higher risk myeloma, or myeloma which is harder to treat, versus other mutations. We can look at the genetics in many different fashions, which they talk about on this slide, but I'm going to move on. Myeloma is staged. This is also a prognostic factor. So patients, and we look at something called a beta-2 microglobulin, which is a protein in the blood, which is reflective of activity of multiple myeloma. And we look at something called the LDH, which is also a factor of activity. And then we look at the genetics of the myeloma. And then we decide if people are stage 1, 2, or 3. Stage 3 is the highest risk patients. And if you look at all patients with stage 3 versus stage 1, and you just look back, so 1,000 in each, patients with stage 3 are expected to not survive their disease as well as someone in stage 1. But for any one individual, it's very hard to say. Moving on. So treatment of multiple myeloma. So let's just kind of back up. I mean, I think what we really do need to know is that the majority of patients with multiple myeloma are not cured of their disease. That said, we all have patients in our practice who are treated for multiple myeloma and have been off treatment for 10 or more years. And and we're hopeful that those patients are potentially cured. We have patients who have bone marrow transplants from other individuals called allogeneic transplant, patients who are particularly high risk. We have thought in the past that this might improve the chance for cure. Indeed, in the right situation, it does seem that some cures are found, but it's definitely a more toxic treatment than the more common autologous transplant. And and only rare individuals are found to be eligible for that approach. And even that is no guarantee that you're going to be cured. With that said, with the advances in multiple myeloma have been tremendous during, in the last 15 years of my career, there have been more drugs that have come out for multiple myeloma. And I think we'll have a slide later on which shows that the survival rate from the time of diagnosis has improved over the decades significantly, and we are still hoping that we will be able to cure more patients in the future. And I really have little doubt that we are going to be able to get there. But we're still working on it. Okay, moving on. Treatment planning. So the treatment for multiple myeloma, there are a lot of different effective drugs for multiple myeloma, and the drugs that we use for treating multiple myeloma, the frontline drugs have changed significantly in recent years, but we have a large armamentarium of drugs that we've had around for 40 years, and many newer drugs. And so how to use these drugs in combination to get the best response and have patients live the highest quality of life, that's our goal. And some of these drugs all have different potential side effects. Patients, for example, some drugs may contribute to injury to nerves or neuropathy. Patients who already suffer with neuropathy from other causes, such as diabetes, that might not be the best drug for them. So we choose the drugs based on their effectiveness and their side effect profile and what the patient's tolerability is. And that's why they said age. There's no upper limit age for which one could be treated for multiple myeloma. I'm sure there are patients who have been diagnosed at over 100 who have been started treatment for multiple myeloma and have derived significant benefit. I know we have several patients in our practice who are in their 90s who have received treatment for multiple myeloma. Many people, if they come in with really advanced disease and they've had kidney injury, sometimes you can have myeloma protein depositing in the heart, or you have underlying other things that can cause heart disease. Treatment can be more of a challenge. And so this is just saying that there's not one best treatment for every individual. Moving on. And I think this is says the same thing. It is a conversation to have between patients. Not all treatments are available in all communities. We're pretty fortunate that there are really no myeloma treatments in the, in the Puget Sound area that are not available to patients. There are some treatments like for relapse patients, like immune therapies using CAR T cells, which patients would have to travel to Seattle to get those treatments. But, that is doable for many patients. If you lived out in central Montana or up in Alaska, your availability to treatments would be far more limited. But it comes down to the middle, patient preference. So when patients know what their options are, they have to work with the doctor and decide what is going to be the best for them. And so there's a lot of discussions that go on at the beginning of therapy. Moving on. So again, there's three sort of major categories of patients who have these abnormal M proteins. I would say that at least 50% or more are in this MGUS category. Smoldering multiple myeloma is another, this is probably, it's another 25, 30%. And active myeloma, when patients present with abnormal protein, it's only probably 25 to 30% of people who present. And these two groups, which probably represent 2/3, are predominantly monitored without initiating treatment. There's been no proof, within the exception of a patient with very high risk smoldering multiple myeloma, that starting treatment early will lead to better quality of life or prolongation of life. And that's a hard thing for patients and doctors alike to understand and to accept. When you do have multiple myeloma, there is we categorize patients to lower, intermediate, and high risk, decide based on other risk factors what the best treatment is, starting treatment. So we call induction therapy. For patients who have relatively good health otherwise. They may be candidates for high dose consolidation therapy, where we harvest their own healthy bone marrow stem cells, give them very high doses of chemotherapy, and reinfuse their stem cells. And this is sort of to knock down the myeloma population down by another log, trying to get them into minimal residual disease, or disease that it's very hard to detect. After this, most of these patients are put on some form of maintenance therapy, and they are then monitored. And then, unfortunately, over time, many of those patients will relapse, at which time we're talking about giving second-line therapy, potential third-line therapy, and then this is talking about supportive treatments, things to help strengthen their bones, things to help improve their anemia, things to help improve their immune system. Okay, moving on. We talked a little bit about active surveillance. So this is the same thing as sort of waiting and watching, and patients who do not require treatment right away, but they do require to come in at intervals to be determined, sometimes every 6 months, sometimes once a year, check their blood and their urine, and if indicated, do additional imaging studies. This is some things that I think are people can do things in a positive fashion to help possibly slow progression of these precancerous conditions to multiple myeloma. And all of these things are really things to help boost your own immune system to help control it. So a healthy diet, exercise, relaxation, getting enough sleep, those things will help maintain your immune system and have the potential to help decrease the risk of progression to multiple myeloma. Moving ahead. So treating active multiple myeloma, well, there's different categories of drugs which are generally used in combination to treat multiple myeloma. They work differently on the myeloma cells, so you kind of attack them from different angles, and this helps patients get a deepest remission from their myeloma and allows them to have longer remissions and live longer. And they run from drugs which affect the sort of the whole background where the cells are developing, and this environment where myeloma cells are dependent upon their environment to grow. These immunomodulatory drugs can affect that environment and interrupt that promotion of myeloma cells. These are drugs which directly attack the myeloma cells, specifically over other healthy cells. And steroids, like we're all maybe familiar with prednisone or dexamethasone, they have an active myeloma killing potential and as well. And so they are used in combination. Moving on. Stem cell transplant. There's two types of transplants: autologous, which is one uses their own healthy bone marrow cells to reconstitute a bone marrow which has had high doses of treatment with these above drugs, including predominantly chemotherapy at the end is used for an autologous stem cell transplant. Allogeneic transplants are those which are derived from other individuals. And I don't really know what bloodless transplants mean, other than you can do a stem cell transplant in patients who are Jehovah's Witness, but it's a little bit riskier. They're going to have very low blood counts. Transplants lead to a profound suppression of the bone marrow and the immune system, and require supportive care with antibiotics generally. Myeloma is also treated with radiation, sometimes surgery. If you particularly have a solitary plasmacytoma, radiation therapy can be part of a transplant to help kill the myeloma cells, sort of covering the whole body, but more often it's used for destructive lesions in the bone, We use agents to help strengthen the bones. Zometa is the most commonly used drug. Complementary therapies may be helpful for patients to get them through myeloma and help improve the quality of their life. There are other medications that we use to help manage patients' other symptoms or side effects from treatment. So different drugs, we kind of went through this. These are the different categories of drugs that are used. Here are some of the names for each of those. These slides are available to you if you're interested in knowing how those different drugs break down. Monoclonal antibodies, they're actually, these are drugs that were, back in 2020, elatumumab is another drug that was available and used. It's not, I don't know why it wasn't included in this, but I somehow shrunk down. Let me see, what did I do wrong? I've got to expand this. There we go. All right, moving on. And that last slide did just say that some drugs are given orally, some drugs are given intravenously, some drugs are given by injection under the skin. So there are many different ways that these drugs are administered. And most people do get combination of drugs from the beginning and down through second, third lines of therapy and more lines of therapy. Induction, as we talked about, consolidation, which is usually what we're talking about is a stem cell transplant to allow us to give high doses of chemotherapy. Then patients are put on to maintenance. And then if they relapse at a later date, they're given second, third line therapies, and there's fourth and fifth and sixth line therapies, which are available, and many clinical trials which are available. And we're fortunate to live in an area where patients can access those trials. Moving on. So treating relapsed and refractory myeloma. Sometimes we will pick drugs. Patients are most likely to respond based upon certain genetic mutations or other markers of their disease. Whether they're in first, second relapse, their general health is very important as far as which drugs they are going to be helpful for them and will not cause more side effects. And the availability of clinical trials is very helpful. And again, always you have to look at what are the side effects of the drugs and what side effects can that patient tolerate. Moving on. It's kind of interesting in multiple myeloma. Patients who have had multiple myeloma and they become resistant to a drug, you can go through 2 lines of therapy and then you can go back to that first line of therapy because whatever that you might have used first, and it may be effective again. And that's because myeloma will mutate. Although it starts as one clone, that can mutate into different clones, and those clones can become, that initial clone may become resistant to that first line of treatment, but a second clone that comes off and becomes a dominant clone may become sensitive to that treatment. And so it's an interesting thing. And one of the great areas in multiple myeloma of active research is to testing the myeloma cells for sensitivity to drugs. And this is an area of active research currently. Supportive care, complementary care therapies. I'm happy to answer questions about that later. Moving on. This again, we can talk about individuals. These are different drug combinations which are commonly used, and some drugs are not approved in the first line setting and only approved sort of in second line setting because that's how they were studied and it got approval by the FDA. But it's always changing, I can tell you that. Moving on. moving on. Clinical trials. And I think that this is just worth a little bit of discussion. What are clinical trials? So clinical trials are generally looking at drugs or a combination of drugs, and they may be already known to be effective in multiple myeloma, but they're trying to see if they might be more effective in the initial upfront treatment, what we call induction therapy, as opposed to an older regimen. That might be one form of clinical trial. Another clinical trial might be a drug which has shown some promise in multiple myeloma, and it's being used for patients who have had relapsed myeloma, and all patients get the same drug. It's not, very rarely is it compared to a placebo. That doesn't really happen in multiple myeloma. But clinical trials can happen at any stage in the course of one's illness with this disease. And these are where we're trying to show that there's a benefit over some other more conventional treatment. And patients are, these trials have to go through lots of hoops to even become available. And we are not really able to treat patients with multiple myeloma outside of specific guidelines. And when it comes to clinical trials, they have to jump through a bunch of hoops, and it does then allow us the ability to access newer treatments for patients. And some of these trials are not even drug trials. In this case, minimum residual disease testing. So these are testing that we look at patients to help see if there's any detectable myeloma after effective therapy. So it's something that during one's course with multiple myeloma, they're likely to come across discussions about clinical trials. Moving on. Bone support. We do know that there are drugs which myeloma can cause destruction of the bone, and we can give medications and supplements like calcium and vitamin D, and recommend support, physical therapy that can be helpful in helping those bones heal, in addition to treating the underlying multiple myeloma. Sometimes that can cause pain in the bones, and we need to treat those patients with radiation therapy, pain medications. Sometimes we need medications to treat neuropathy pain. And that's what they're talking about. Anticonvulsants and antidepressants can sometimes actually help with pain control if it's due to nerve damage. Moving on. Your healthcare team. So you're going to be, if you have multiple myeloma, you're going to have a specialist in multiple myeloma who's a hematologist oncologist. There are hematologists and oncologists. Since myeloma is a relatively common form of cancer, virtually everyone who is certified as a hematologist oncologist has a significant amount of experience treating patients with multiple myeloma. If you are at a tertiary care center like the University of Washington, you may see a doctor who specializes in multiple myeloma or multiple myeloma and some other form of cancer, a limited number of cancers. And feel free to ask your doctor about their interest in myeloma, their experience in managing multiple myeloma, and we're going to go on. We're talking about it's very reasonable and helpful to get a second opinion. I personally encourage patients to get a second opinion because I want them to feel comfortable that they are getting the best quality of care. We often will send patients up to Seattle to have their transplant, their autologous transplant, as part of their initial treatment, and that thereby they've had a second opinion, and they have a second team of myeloma specialists who we can access to help make treatment decisions down the road. Moving on. You have the right to a second opinion. Insurance companies actually generally will have no problem paying for a second opinion. When it comes to multiple myeloma, the cost of doctor care and visits is pales compared to the cost of the drugs. And I hope Abra or some of the team can tell a little bit about what they do, because a big part of multiple myeloma is to help people access these expensive new treatments for multiple myeloma. Unfortunately, we are highly effective at doing that, which, helped by the generosity of the manufacturers of these drugs and other foundations that allow patients to access the best treatments that are available for multiple myeloma. And there's rarely a case where finances prevents somebody from accessing the best drugs available to them. Moving on. Palliative care, what is palliative care? This is symptom management primarily, helping patients with side effects of treatment, side effects of their cancer, emotional stress, and it's appropriate at any time in the course of any chronic illness. But certainly multiple myeloma, there's plenty of room for palliative care. Moving on. Open communication, it's a two-way street. Unless you tell us that you're having problems, we're not going to be able to help you with those. I mean, certain doctors are better at bringing those concerns of patients out, but don't be shy about asking your doctor questions or telling them about what's bothering you. Moving on. And questions about your myeloma. It's as you can see, it's a complicated illness. There's many different ways it presents, many different treatment options. How do you monitor it? How do you handle the costs of therapy? And what are your options down the road? Moving on. Clinical trials we touched on. Being able to take a break from treatment, I think that's a very important question. And for the most part, patients on multiple myeloma do get put on some sort of a maintenance therapy to help keep their myeloma in remission. But those maintenance treatments, some of those are oral that can be taken on vacation, but most often, patients can take breaks from their therapy and not lose any ground. Great, okay. So again, this is just sort of summarizing how we choose what treatments are. Those choices are based upon their presentation, patient individual conditions, where they are in their course of treatment and how they've responded to prior treatments, if there are available clinical trials, and that this myeloma protein is a good marker for the number of myeloma cells in the body, and we want to keep both of those low. Now, just to clarify, not everybody, people can have a lot of myeloma with a little bit of myeloma protein, sometimes no myeloma protein. Some patients have a very little bit of amount of myeloma that makes a lot of myeloma protein. So the amount of myeloma protein doesn't necessarily correlate directly to how they're doing, but it is very useful. Moving on. Coping. So I think let me just see the next slide. This is just about staying healthy. Okay, well, anyway, the last slide was fine. It was just about things that you can do for yourself to help stay healthy, both physically and mental health, getting support, avoiding infection. It was something that's really kind of was underrepresented in this slide deck, is that patients with multiple myeloma do have a degree of immune compromise, which waxes and wanes over the course of their illness. And so they do need to be careful and watch for signs of infection. We've talked to patients who are undergoing active therapy, and we let them know that we want them to get the COVID vaccination, but they may not have as robust a response to COVID vaccines or other vaccinations. And so they need to remain somewhat vigilant and careful about exposure to to infections and to bring any signs or symptoms of infection to their healthcare team to help manage it and catch it and treat it early. Moving on. So this is an exciting time for this disease. We know so much about this disease and we're still learning. There's a lot of active research going on across the world in multiple myeloma, and there's a lot that that doctors are learning, but there's also a good support community out there that can help patients live the best quality of life that they can during their course with multiple myeloma. And there's always hope for a cure. And I think that's it for me. Wait, these are some slides. This is not it for me. There's something I wanted to tout a little bit, and that is a program that we have available for us called All for Cure. And All for Cure is primarily centered on multiple myeloma, and it was founded by the husband of Dr. Sibel Blau, who is our the medical lead in Northwest Medical Specialties, and her husband is also a cancer specialist who was a longtime faculty member at the University of Washington and Seattle Cancer Care Alliance, who unfortunately came down with multiple myeloma himself, and has recently retired from the university to found this both support and research network foundation called All for Cure. And these are a few slides that he provided for me. And this is just looking at some of the progress. This is what the median survival is. And this is sort of the introduction of these drugs and what has happened. So in 1960 down here, we could see that from presentation, half people were dead from their disease within 3 years. And if you look at it now, we don't even really have a defined median survival. It's somewhere probably between 8 to 10 years from presentation for a large population. Now, some of those patients don't do well and they die earlier. Some of those patients live for 20 or more years. And this is overall survival. This is not myeloma-specific survival. You have to remember that most people who present with multiple myeloma are over the age of 70, and there are a lot of competing risk factors causing their death. So if you look at this is not a death sentence for multiple myeloma, but I just wanted to show you that progress over the decades has been tremendous as far as what we're doing to help keep people going with multiple myeloma. Next slide. So All for Cure takes patients volunteer to have their information curated, and it's taken in, and they take all of the markers of their myeloma markers, including their M proteins, their anemia, their blood counts, and they track them out over time, and they track them out against these upper markers are the treatments that they've received. And so this may be like a myeloma protein that you're seeing, and then and this treatment may not be that effective. Then they start a new treatment, and you can see those markers go down. The drug relapses, they start a new treatment, it goes down. And so these are different aspects. And so this is what we see the patient sees and their doctor sees, called their dashboard, that looks at the markers of their myeloma, the treatments that have occurred for their myeloma, and how those are over time. These are identifying things that it's all confidential, and we don't know who any individual is. They're identified by number as opposed to name, but it tells a little bit about sex, age, and the type of myeloma they have. Next. Oh, this is just some testimonies from different doctors in the area, both some of our local doctors at Northwest Medical Specialties, international leaders in myeloma who have had access and have been using All for Cure, and also leaders in multiple myeloma from Seattle. Dr. Benzinger, who's at Swedish, who many of our patients get to know over their time because he has lots of clinical trials for relapsed myeloma. So, and next slide, please. Maybe that's it. But All for Cure, I want to let you know that if you are a patient with multiple myeloma and you have not had a discussion about All for Cure, you should talk to your doctor about it, because this information is very helpful to the way it's presented and kept. It's easier place to track your disease, and it's useful for looking down, retrospectively to see what drugs have been helpful for different types of myeloma patients. So there's research potential for it. And I think most people who have a disease are hopeful that when they, that they're even after they have been treated, that their experience will be useful for helping other patients down the road. And organizing the information like this really enables that to occur. And I think will help move the whole field of multiple myeloma along further. So All for Cure, I'm a great proponent of it. And I encourage any patient with myeloma to ask about it. Moving on, Abra.
Oh, thank you, Dr. McCroskey. Yes, this is my first time using a MacBook, and I kept accidentally logging myself out somehow. So sorry about that. Okay, so Dr. McCroskey had asked me just to share a few resources with the group tonight about, internally, what do we have here at Northwest Medical Specialties to help support our patients through this, and knowing that this is also a presentation open to anyone in the community affected by cancer. These are all things that are provided I would say in our area. I can confidently say they're provided at these oncology centers also. But here at Northwest, we do have a team of financial counselors. So Dr. McCroskey did mention a little bit about the cost of treatment and kind of talking about the maintenance and over time, how long someone might be on a treatment. So our financial counselors, they are available to meet with our patients to look at what their out-of-pocket cost might be, and then to help locate foundation or assistance to help alleviate that cost, and so it's not being passed along to you. In addition to the financial counselors, we also have patient navigation, which helps with practical barriers that you might experience to care, such as transportation, any kind of financial, insurance, housing, food, care at home. So they really are a great resource to tap into to help get you connected to any community-based resources that might be helpful in your cancer care. And then also we have social work, myself, Caitlin, all the cancer centers here in the area have social work as well. And we're here to help provide emotional support. We do short-term counseling, facilitate support groups. So we try to really encompass the whole picture. And, we know that you're not just going through cancer, but how it's also impacting and touching all these different areas of your life. So with that said, if you have questions about kind of what we offer here at Northwest or how to get connected, our contact information, we can add that into the chat as well. Most all of you, I think, should have Eunice's email, and we're happy to help get you connected. This slide here talks a little bit about some of the specific resources that Cancer Support Community provides on a global level and national level. So the Cancer Support Helpline is a great way to connect with licensed professional counselors that are able to assist you Monday through Friday from 9 to 9. So definitely use this line if you're wanting additional support from a counselor. They're very helpful, and as well as their social worker here at the clinic. The other program that Cancer Support Community offers is Open to Options. And this is where a helpline specialist will actually help guide you in creating a list of specific questions that you might want to ask your doctor about concerns that you might have. So this is a great way to just kind of gather your thoughts and be able to bring that to your appointment. And then Frankly Speaking About Cancer is what we're doing tonight. This is all provided through Cancer Support Community's Frankly Speaking About Cancer, and providing trusted information on a variety of topics that are important to people affected by cancer. So just a little bit about the resources. And then here are some other helpful links that you might go to for additional support. So Cancer Support Community, Leukemia and Lymphoma Society, Multiple Myeloma Research Foundation, International Myeloma Foundation, and the National Cancer Institute. So again, all these slides will be going out, so you should have access to this information, as well as we'll have a recording, like I said. And that is all I have for the resources. So we wanted to open it up for questions. So I'm going to give it to Caitlin so she can help facilitate some of those questions for Dr. McCroskey.
Great, thank you. So we had a few, we're going to stop the recording now so that people can feel comfortable sort of turning on their